That is how all self-done videos.
All right. Hello, everyone. Over the past 12 months, there's been a lot of new reports published on the association of clarithromycin and acute kidney injury. And so today we're going to discuss a little bit of what the evidence is behind these reports and why we may be seeing some of this acute kidney injury associated with clarithromycin use with other medications. I'm Eric Wamwell. I'm a professor of pharmacy at the University of Missouri, Kansas City School of Pharmacy. And one of my practice sites is Centerpoint Medical Center, and I'm here with Aaron Herman as well as with Kinsey Maxwell, who are students with me. And we're just going to be discussing some of that literature that's available. Clarithromycin, name brand Bioxin, is a macrolide antibiotic with that's used in upper respiratory infections like sinusitis, bronchitis. It can also be used in lower respiratory infections like pneumonia, and then also one of the primary places that we may be seeing it used is in peptic ulcer disease for H. pylori. So those are some of the primary uses, but one of the things that's specific to clarithromycin and the macrolide class is the potential for inhibiting the CYP3A4 metabolism pathway that occurs in the liver. And so when that inhibition occurs, then there's the potential for other drugs that go through that pathway for metabolism to accumulate and achieve higher concentrations within the body. So one of the reports, one of the classes of drugs that does utilize the 3A4 system is the statins, and that's where we're starting to see some reports. And Aaron, what kind of data did you find on that?
Well, the first study is a retrospective observational analysis of healthcare databases in Canada, United Kingdom, and the United States. It found a correlation between high doses of statins and acute kidney injury. The study looked at high-potency statins versus low-potency statins. And a high-potency statin was defined as 10 milligrams or more of rosuvastatin, 20 milligrams or more of atorvastatin, and 40 milligrams or more of simvastatin. All other statin treatments were defined as low potency. The primary endpoint for the study was hospitalization for acute kidney injury. Over 2 million patients were analyzed, and a third of them received high-potency statins. The average age of study participants was 68 years old, and what they found was that patients who started high-potency statins were 34% more likely to be hospitalized for acute kidney injury than those who started low-potency statins in the first 120 days of treatment. So, high statin levels can cause acute kidney injury, and so that's where the other studies that I'm going to look at the inhibition of CYP3A4 with clarithromycin given with a statin that can raise the statin levels. The mechanism by which statins cause AKI is yet unknown. However, there is evidence that increased statin levels can cause acute kidney injury. The next study found that CYP3A4 metabolized statins can lead to higher incidences of AKI and other adverse events when co-prescribed with strong CYP3A4 inhibitors, such as clarithromycin. The statins investigated in the study were atorvastatin, simvastatin, and lovastatin. The macrolides investigated in the study were clarithromycin, erythromycin, and azithromycin. Azithromycin does not inhibit the CYP3A4 enzyme, so patients receiving azithromycin were considered the comparison group. And then what they found was that simvastatin and lovastatin could display up to a 10-fold increase in concentrations, and atorvastatin could increase up to 4-fold. And then the outcomes that they found, the adverse effects found in the study were rhabdomyolysis, acute kidney injury, hyperkalemia, and death from statin toxicity. And the risk is greater in older adults. The study was a population-based, retrospective cohort study of adults greater than 65 years old. The individuals were eligible after their second consecutive prescription for a statin, and they remained in the study as long as they were receiving a statin. Co-prescriptions of clarithromycin, erythromycin, and azithromycin were then identified. The primary outcome of the study was hospitalization with rhabdomyolysis, and then the 3 secondary outcomes were hospitalization with acute kidney injury, hospitalization with hyperkalemia, and all-cause mortality. The patients were identified with these outcomes when a physician would enter a diagnostic code corresponding with that respective outcome. Since the diagnostic codes were very specific, the authors believed that the data received would be an underestimation, since a patient may not receive a diagnostic code if their disease state was a mild case. Therefore, the authors also examined a subpopulation based solely on elevated lab values. So for rhabdomyolysis, it was creatine kinase. For acute kidney injury, it was serum creatinine. And for hyperkalemia, it was serum potassium. Since we're looking at acute kidney injury today, what they found was when a CYP3A4 metabolized statin is co-prescribed with clarithromycin or erythromycin, the risk for hospitalization with acute kidney injury increased by 78% over co-prescription with azithromycin. And in the subpopulation, which is the population that the authors would provide more accurate data, the risk for hospitalization with acute kidney injury was almost 3 times as likely over co-prescription with azithromycin. And then the absolute risk for hospitalization with acute kidney injury was increased by 1.26%. The other outcomes in the study, they found that the risk for hospitalization with rhabdomyolysis increased by 217% over co-prescription with azithromycin, and the risk for hospitalization with hyperkalemia increased by 31%, but was not found to be statistically significant. The risk for all-cause mortality increased by 56% over co-prescription with azithromycin, and then finally the absolute risk of all-cause mortality increased by 0.25%. All that data was based on the diagnostic codes. Also in the subpopulation, which they hoped would have more accurate data, the risk for hospitalization with hyperkalemia was 11 times as likely over co-prescription with azithromycin, and the absolute risk for hospitalization with hyperkalemia was increased by 0.74%. Some of the limitations of the study included that atorvastatin was used 73% of the time, so it was definitely studied more than simvastatin and lovastatin. Clarithromycin was used more than erythromycin, which is fine for our discussion because we're targeting clarithromycin anyway. And then one thing to keep in mind is that the duration of therapy differs. So clarithromycin and erythromycin in the study were used for 10-day courses of therapy, and azithromycin was only used for 5 days. So that potentially could play a role. And then also, since elderly patients are often on many medications, it is possible that other co-prescribed medications may have played a role in the data as well.
So let me stop you there real quick, Aaron. So this study was specific to the statins that have 3A4 as a primary pathway with which they're metabolized.
That is correct.
And definitely showing a strong incidence of acute kidney injury associated with their co-prescription with clarithromycin and erythromycin, which both inhibit very strongly 3A4.
Correct.
And then that was in comparison to azithromycin, which we know has very little 3A4 inhibition. And one of the things that you've kind of picked out as a limitation is the 10-day prescription versus the 5-day prescription. Now, when we're looking at azithromycin versus clarithromycin and erythromycin, why is the azithromycin the 5 days? Just so our audience can understand that a little bit.
Well, azithromycin has a longer half-life, so it has a half-life of about 48 hours. So it doesn't need to be given as long. Its action will last longer than clarithromycin and erythromycin.
Okay, so we'll probably end up with about the same length of therapy overall when you include the half-life.
True.
Okay, good. Very good. So that was 3A4 specific statins. Is there any evidence for statins that are that weekly go through 3A4 for metabolism?
Yes. Another study was conducted, and it's basically the exact same study as the one we just went over, but instead it compares clarithromycin to non-CYP 3A4 metabolized statins. And this study found that acute kidney injury and other adverse events were also found to occur when clarithromycin was co-prescribed. This sounds counterintuitive at first. However, there is an entirely different mechanism that is suspected to be at work here. There are liver transporters called OATPs, or organic anion transporting polypeptides, and these transporters facilitate the movement of statins into the liver to be metabolized. Clarithromycin inhibits these transporters, and therefore might raise non-CYP3A4 metabolized statin levels also. Incidentally, azithromycin, once again, does not cause this inhibition, and so azithromycin co-prescription patients were once again used as the comparison group. The statins, non-CYP3A4 metabolized statins for this study were rosuvastatin, pravastatin, and fluvastatin, and the outcomes were hospital admission with a diagnostic code for rhabdomyolysis, acute kidney injury, hyperkalemia, and all-cause mortality, just like the previous study. When a non-CYP3A4 metabolized statin is co-prescribed with clarithromycin, they discovered that the risk for hospitalization with acute kidney injury increased by 46% over co-prescription with azithromycin. So in comparison, the other study, it increased by 78%. So it's not quite as strong here, but it is still, there's still evidence that it occurs, the interaction occurs. And then the risk for hospitalization with hyperkalemia increased by 87% over co-prescription with azithromycin. And the risk for all-cause mortality increased by 32% over co-prescription with azithromycin. The number of hospitalizations with rhabdomyolysis was minimal, and the risk increase was not statistically significant. So the study barely touched on that. Now, the risks that I've been giving you are the relative risk of using clarithromycin co-prescription as opposed to azithromycin co-prescription. But the absolute risk increase for each outcome was actually very small. Even under the assumption that the diagnostic codes underestimated the outcomes by 5-fold, the absolute risk increase for each outcome is still less than 1%. So though the absolute risk increase for acute kidney injury, hyperkalemia, and all-cause mortality was very small, statistical significance was still found. The FDA currently recommends the use of non-CYP3A4 metabolized statins as a safer alternative to CYP3A4 metabolized statins when taken with CYP3A4 inhibitors. However, healthcare providers should be aware that the same adverse effects can be found in both populations.
Good. No, I think that's an important point to pick out there, is the absolute risk versus the relative risk, where overall, if someone is given clarithromycin and they're on a statin, less than a 1% chance that they're going to have acute kidney injury, very small chance. But if we compare that to their risk with azithromycin, their risk goes up much more.
Correct,
versus azithromycin. And so I think that last piece you were talking about with the recommendation as well as to what to do if you have a patient that's on a statin. If you got a patient that's on a statin and you're starting a clarithromycin for a 7 to 10 day course, it may be worthwhile holding that statin in the interim, or choosing an alternative azithromycin for that patient if they're on a statin for their patient. Good. Thank you very much, Aaron. That was great information.
You're welcome.
So one of the other classes of medications that we're seeing some of this evidence of acute kidney injury in associated with co-prescription with clarithromycin are the calcium channel blockers. And so, Kenzie, you've got some information on that for us as well, correct?
Yes, I looked specifically at calcium channel blockers which are metabolized via CYP3A4. So I found 2 trials and then 1 literature search that looked at specific case studies related to this interaction. So the first trial I want to talk about looked specifically at clarithromycin with calcium channel blockers causing acute kidney injury. This study did find that clarithromycin co-prescribed with a calcium channel blocker was associated with a higher incidence of hospitalization with acute kidney injury than a co-prescription with azithromycin. This was a population-based retrospective cohort study that looked at adults older than 65 in the Ontario, Canada region that received either a co-prescription with their calcium channel blocker of clarithromycin or azithromycin. They used azithromycin as the comparator group because it has less 3A4 activity and isn't really considered an inhibitor. Since the instance of acute kidney injury based on hospital diagnosis codes, which was used in this study, can be underestimated up to 5-fold times, they looked at a subpopulation of patients based just on absolute increases in serum concentration as well. So they saw 109,000 patients identified, 96,000 on clarithromycin and 94,000 on azithromycin with all similar baseline characteristics. With the primary outcome, hospitalization with acute kidney injury, clarithromycin was associated with a higher risk compared to azithromycin, a 0.22 higher incidence of hospitalization. And in the subgroup analysis, clarithromycin was associated with a higher risk compared to azithromycin. So they were just looking at absolute increases in serum creatinine, and that was a 0.7% higher incidence. And then a secondary outcome was hospitalization with hypotension. Since hypotension can cause acute kidney injury, they also wanted to look at that and see if that played a role. So clarithromycin was associated with a higher risk compared to azithromycin, just a 0.04% higher incidence though. And then they also looked at all-cause mortality. And clarithromycin was also associated with a higher risk compared to azithromycin, a 0.43 higher incidence rate. So even though these absolute increases were small, the outcomes still have important clinical applications since acute kidney injury has been shown to affect morbidity, mortality, and overall hospital costs. So it's very important to take that into consideration. Also, since this was looking at an older population, it's generally safe to say that this is related to elderly populations and not young, since we only looked at patients older than 65. So my second study just looked at co-prescription of any macrolide antibiotic causing hospitalization with hypotension, since we can make the connection that hypotension can cause acute kidney injury. So they looked at erythromycin and clarithromycin, and both were associated with a greater risk of hospitalization for treatment of hypotension or shock than azithromycin. So they looked at about 100,000 patients, and 70 out of those patients, 7,100 were admitted to the hospital for treatment of hypertension, and about 176 patients had received a macrolide. So the primary outcome was the admission to the hospital with treatment of hypotension. So they showed that erythromycin had a strong, statistically significant association with patients being hospitalized for treatment of hypotension. And clarithromycin also showed a statistically significant increase in the odds of being hospitalized for treatment of hypotension. And there was no association shown with the use of azithromycin. So this study was conducted in the same way as the previous study. It only looked at elderly patients over the age of 65. And it also did use diagnostic codes, but they did not look at a subpopulation. So it's safe to say that this would be underestimating the actual results, since diagnostic codes can be at least 5 times off of what it's really seen in the population.
Now, Kinsey, in that study, what was the increased risk? What was the odds ratio that they saw with the increase in hypotension?
For erythromycin, the odds ratio was 5.8, and clarithromycin was 3.7.
Okay, so pretty significant there from a clinical standpoint when you compare clarithromycin and erythromycin to azithromycin.
Yes.
Okay, good.
And then lastly, it was just a literature search done by a group of people that looked at specifically case reports related to the interaction between a calcium channel blocker when it was co-prescribed with a CYP3A4 inhibiting calcium macrolide. So this study found 5 case reports. It is important to note that 3 out of the 5 of these case reports were associated with verapamil. So this looked more at the non-dihydropyridine calcium channel blockers. But overall, out of all 5 of the case reports, they found the same things, that the co-prescription of a 3A4 inhibiting macrolide did increase the concentrations of the calcium channel blocker and did lead to adverse effects such as hypotension and decreased heart rate. So another important thing to note with this case report study was that it did look at specifically non-dihydropyridine calcium channel blockers because there were more case reports associated with that information. And since the non-dihydropyridines have less peripheral vasodilatory effects, but they do have increased effects on the coronary arteries. So there's an increased risk for cardiac complications associated with specifically non-dihydropyridine calcium channel blockers. So it's important to note that as well when looking at elderly patient population on those medications. It's also important to note that non-dihydropyridine calcium channel blockers are also 3A4 inhibitors themselves. And so clarithromycin has been shown to prolong QT intervals just on its own when it's given without any other medications. So when you give it with a non-dihydropyridine calcium channel blocker, which is a 3A4 inhibitor, it's going to increase the risk of clarithromycin causing a QT prolongation. And then also if you're increasing the concentrations of the calcium channel blocker, you're also going to increase the risk of having QT prolongation. So that would be a significant interaction that you would want to keep in mind on patients that are taking those medications together. So they wanted to look at this interaction because it's very common to see these medications co-prescribed together. Even though there are warnings in the prescribing literature to keep these in mind, people still do it all the time. So that's why they wanted to look at this information in these studies to provide more information. So hopefully we can prevent more cases of acute kidney injury from occurring. So just some general recommendations that I came up with when reviewing this literature were that if you do need to use a macrolide antibiotic, it's recommended that azithromycin be used over clarithromycin or erythromycin just to reduce the risk of these adverse effects occurring. Or if you do need to use clarithromycin, you could stop the calcium channel blocker just for the treatment period on those patients, especially in older patients that are have multiple comorbid conditions. You'd want to be safe in those patients. So.
Very good. And real quickly, the reason that hypotension is associated with the acute kidney injury is as your blood pressure falls, so does your perfusion of the kidney being one of those organs that operates on a very low amount of oxygen already, and so as we reduce the amount of oxygen coming to that organ with the reduction in blood pressure, that definitely puts the patient at risk for acute kidney injury without being properly perfused. I think what's most profound about all of these studies when we take them all together is that we're specifically looking at patients that have been hospitalized with acute kidney injury. We're not even taking into consideration these mild or moderate elevations in acute or in serum creatinine or small impacts on kidney functioning or small impacts on hypotension, and did someone fall and we not relate that back to hypotension that they had in association with their clarithromycin and calcium channel blocker. So I think we're probably just getting the very top of the glacier on this, and definitely something that we need to have an awareness of when it comes to drug-drug interactions and co-prescription of clarithromycin with any medications that do go through the 3A4 system, with a preference for using azithromycin in those patients. The other thing to take into consideration is that in the patient population where we're using clarithromycin or any macrolide, these are patients with an infection who are already going to be at risk for having acute kidney injury because they may have vomiting or diarrhea, poor oral intake. So they're going to be dehydrated already, which can certainly have an impact on their kidney functioning. So definitely some good food for thought. I appreciate your guys' work on this, appreciate the information. It's very enlightening, and I appreciate you there in the audience sitting in with us today, and hope you have a good rest of the afternoon. Ta-ta.